we'll get started. Why don't we go around and just introduce who everybody is and kind of run this as a small group session. I'm Shannon McNamara. I'm the simulation director at NYU Bellevue in New York City. I've been working on clinical event debriefing through a collaborative in New York City for, when did we start this? A few years.
In concept, maybe even 4 years ago.
And that's kind of this composition of this group in varying degrees. And we're excited to talk about this with you all today and give you some practical advice.
Actually from Australia, I'm sort of like a program director there. I do a lot of simulation, and I was mentioning to Shannon about a framework that a colleague of mine was using called the Talk framework, which they've got a website. It's, I think they developed it from the University of Cardiff, and they've used it in a few places around Europe, so be interested to see how you guys do it.
I'm Liz B. Thomas. I am full-time faculty at the new medical school in Connecticut, Another School of Medicine, which just graduated our third class last week. And
Congratulations.
Thank you. We have a big EM contingency every year. I'm interested in critical incident address debriefs and doing some scholarly work around creating a more useful model for community practices outside of the academic institutions. So I work in a community hospital and being able to actually debrief with my team in the moment. So we call it diffusing, right, instead of a full debrief. And so I am interested to hear what you guys have to say.
All right, cool. Amish Aghera. I work at Maimonides Medical Center in Brooklyn. I'm the director of the Simulation Division and Fellowship there. And like Shannon, have been working with this project since the beginning. And it's like now slowly starting to evolve into other interesting domains, which I think we're going to share with you guys a little bit.
Yeah. Hi, I'm Annemarie Cardell. I am one of the simulation fellows at Maimonides. With Amish, I actually came into this in residency when she was debriefing our recesses, and then now I'm training our residents how to do it.
I'm Pam. I'm also from Maimonides as a simulation fellow. Got involved actually in the fellowship. So.
I'm sorry.
No, go ahead.
I'm Christina Hajicharalambous, the SAEM Medical Education Fellow at Mount Sinai, New York. I started getting involved, I would say, right before fellowship started when I took the course about a year or so ago.
Hi, I'm Lamberta. I'm also in Maimonides Medical Center where I did fellowship. I stayed on, so I've been working with Annemarie and Pam as well. Training our residents. I was part of also our faculty development training that brought CED, trained all of our ER attending faculty, and yeah, just facilitating. Monthly we have a senior resident that we do sort of like an abbreviated clinical event debriefing and try and assist them in performing it in the ED or just ourselves, on clinical, during our clinical time, facilitating these debriefings or at least encouraging that they be performed during our events.
So to give you some context for where we're coming from and our goals for today, so our project evolved from doing simulation in the sim lab to in situ simulation in the ED to saying, if we're already debriefing our simulations in the ED, why aren't we debriefing our resuscitations the same way? And what would that look like and how would that be different? And then looking at the literature on after action reviews and clinical debriefing and critical incident stress debriefing and all these, there's a lot of different language for the act of reflective conversations at the bedside after an event to say, how can we do better or what just happened? And so we evolved our own approach, and there are lots of different approaches out there, and the literature is really in an area of tremendous growth right now as we try to put all these things together. And so our goal today was to do a practical approach. So the learning objectives we wanted to cover are to discuss the risks, benefits, and logistics of conducting a clinical event debrief in the ED. So what we're talking about is a hot debrief right after resuscitation and how to do that. the risks and benefits based on the literature that exists and from our own experience of doing hundreds of these at different hospitals in New York City as a collaborative, to give you the opportunity to co-lead a simulated clinical event debrief in a facilitated small group setting. And based on our numbers, I wonder if we could split maybe into 2 small groups and debrief the first one and then talk about the second one in the interest of time. Does that make sense as our group? And so you can actually practice and give you a structured framework for debriefing clinical events in the ED. So we're giving you the structured framework we're using. The talk framework's another one. The info one is another one. And in your handout, there are lots of literature on more. So we printed up the handout. If you prefer to have the PDF of the handout, you can use the QR code to download it, or it should be on the SAEM website. So you can relax a bit of note-taking. There's a lot there. And so in that handout particularly, there is an AHA document that's a PDF of like 10 different formats of CED that different institutions have tried. Because there's so many different ways to do this. And we're kind of all figuring it out. There's not like one best way that we know. So we're showing you what we've tried and what seems to work well for us. And after, at multiple institutions and many different people, this is the way that works, but there are many different ways to try. So I've tried to give you everything out there that I know of on this, and there's more. Like Victor brought up talk, which is not in here, but there are many. And CISD is another thing. We're going to bring up how we manage second victim syndrome in the context of clinical event debriefing, which is really important. So you have this. So hopefully by having this, we can focus on the practice today. So I think we talked a little bit about everybody and their goals. So ultimately, I think a big question is, why are we debriefing? What's the point? It's when we talk about deliberate practice, looking at the graphic here, just doing doesn't make us better. But deliberate practice where we do something, we get some feedback on how did it go, we try to improve, and then we do it again. That's how we get better. So debriefing, where we say, hey, how did that recess go? What happened? What went well? What didn't go so well? Why? How can we do better? Let's do it again. So that process helps us get better as a team. And that helps us improve future performance on the individual, the team, and the systems level. And, go ahead.
Can you help me make a distinction between debriefing for the purpose of after a traumatic event or emotional event versus process improvement? Are those two different types of debriefing, or could they merge together?
You've highlighted one of the most difficult pieces of this, which is that traditionally, people talk about operational debriefing and psychological debriefing. So like clinical incident stress debriefing is psychological debriefing. We often talk about operational debriefing. What we all know as emergency physicians is that when someone dies in your ER at 3 a.m., there's no such thing as psychological and operational debriefing. It's just debriefing. Someone just died in your ER and your staff want to talk about it. So we will cover that more, and there's not an easy answer. But you have hit the nail on the head. So I think a really important thing for us to think about with learning, in medical education, we focus almost exclusively on individual learning. Debriefing focuses much more on team and organizational learning. And that's a really key mindset shift, that it's not, Annemarie, let's talk about your intubation skills. It's team. How did we do taking care of this patient? Did our organization set us up with the systems that we need to take care of this patient? Were there any latent safety threats in our environment that we need to address? So the conversation is a very significant mindset shift from how medical education normally functions. When we're talking about, what are we talking about when we talk about debriefing? This is a graphic from the Pearls tool of debriefing, which you'll find in your handout. And things you can talk about. You can talk about decision making, technical skills, communication, resource utilization, leadership, situational awareness, teamwork. I think it's not necessarily just medical management. And it's a really different model from traditional bedside teaching. I find it tremendously valuable and really interesting as an interprofessional conversation around patient care.
So basic anatomy of a debrief. So I think we've already mentioned that there's a lot of different ways to do it, but the key is no matter what method you choose, it must be structured and grounded in some sort of like best practices, right? So essentially most debriefs you would divide into 3 phases. One is sort of the opening, actually maybe a 4th phase, which is the pre-opening, right? Getting people on the same page. And the reason why that's important, a phrase I like to use is an ounce of prevention is worth more than a pound of cure, because based on the constituents of your team, the culture in your department, the same conversation at site A could go very differently than at site B. So you need to sort of set up the so-called ground rules, right? What are we going to talk about and how are we going to do it? So one is it's hard to have a conversation with somebody if they feel like the pull to go take care of another patient. So you have to give people permission to leave, otherwise they'll never want to debrief with you again because they actually feel like they're hurting someone else. 2, you have to tell them how long this is going to take, right? Usually you can do this in 5 to 10 minutes, and that's usually the framework that we use. 3, our goal is to, at least for the first time we kind of do the workshop and you try this on for yourself, it's going to be focused around improving teamwork and analyzing your sort of clinical systems. And 4, as Shannon said, it's not about the individual, it's about the team. So right off the bat, we say, look, difficult things may have happened, but we're not going to point any fingers. We're going to figure out what we could have done to do better. Usually the debrief starts with a quick summary of the event to get everyone back on the same page. Everyone will introduce themselves and what their role was in that event. And then you talk about, a basic plus delta strategy, if you're sort of used to that terminology. What did we do well and what could we do even just a little bit better? And then you wrap it up with, a closing statement. So again, to rehash, so the pre-brief, what we're doing here, who we are, what happened, talk about it a little bit, and summarize.
I'm sorry, maybe we're getting to this. The what happened piece, what does that look like? That someone comes in, just took care of a 60-year-old male, whatever?
Exactly, right. So oftentimes in the team setting, if you're busy putting in an IV, for example, you may have missed a big picture. So it's good to start off in terms of your best, like the structured aspect of it is before you start getting into the nitty-gritty, you've got to have like a quick one-liner about this was a patient who had chest pain, went into VFib, got shocked, came back, and now is in the cath lab. The end.
Very short.
Yeah, with time, often people like to go through every sort of piece of the resuscitation, but I generally counsel people to be like, just give us one line of what we did, or what was the diagnosis, and we performed, ACLS.
And even when we're talking about the value of debriefing, whether it's in an academic or community setting, often in an ad hoc interprofessional team, like in a big center, people don't know who's on the team, they don't know their names, they don't know their roles, and they don't know what happened. So even that is valuable.
So structure.
Yes, structure is key. It's huge.
100%. Mm-hmm.
And that's really big. So some quick pearls. Brief and immediate help a lot. When we try to wait and do it later, it doesn't happen. Interprofessional, making sure that it's about everybody on the team, not just doctors. Talking to each other and not about each other is a big cultural shift. Building that situational awareness, like you mentioned. Highlighting the positives can be really powerful. I think often people think of debriefing as let's fix problems. Just debriefing, when we started doing this, we would say, debrief what went well. Debrief, pick a kind of thing, like debrief all your intubations, or debrief all your codes, or debrief all your traumas, whatever it is. And then talk about, do the good ones, and say, Annemarie, Christina, the way you handled that airway, or the way you did CPR was fantastic. Or I really appreciated your handoff to EMS. Thank you, and it was fantastic because you did X, Y, and Z. Thank you for that. And then that behavior gets repeated. When you share those gratitudes and you acknowledge good work and why, you start seeing that behavior more and more and more. And it's a really, from a wellness perspective, it can build a lot of positive interprofessional bonding and build more positive patient safety behaviors.
Like just changes, it shifts this culture, you know, when like we have PCTs that we tie in. We had one code where, our techs, we had one house fire that came in, and it was 3, and so we needed all hands on deck. 3 people came in coding, and our techs hadn't been BLS certified, or they had lapsed and they weren't getting supported to get BLS certified. And it took one of these debriefings for that to speak up and go to our SimOps meeting where we were able to promote like BLS certification for our techs who were integral in those sort of mass casualties. Yeah.
And that, I think building that psychological safety when people speak up and saying, thank you so much for bringing that concern up, we need to address that instead of that culture of don't talk about what's wrong because you'll get in trouble. And that's huge when you as a leader in a debrief can say thank you. And so I think from a SIM perspective, that inquiry mindset of focusing on systems, that double loop learning of not just what happened, but why did it happen, and modeling that constructive discussion of system challenges like, oh no, our PCTs need BLS, let's fix it. So we want to practice doing a debrief. Should we split up into 2 groups? And I'll play the video, then we'll split into 2 groups. Okay.
Right, so I think the idea will be that we want to just give you a chance to try on our proposed structure. And, you know, practice makes progress. That's what my 6-year-old told me the other day that she learned in school. That's right.
That's the new.
So,
that's the new way that we're doing it. So, you know, so we want to try to be active learners here as opposed to just talk about it.
So actually, we could split into 3 groups and everyone could debrief this case. What does the group want to do?
Or we could just do a single group.
Or we could just do a single group.
Well, we could let our learners lead. The goal is, so this is I'll tell you, this is a code that goes well. It's a code that goes well, and we want to give you a chance to try on the debriefing.
Right.
We'll run it and then you can decide. So pay attention to this as if you're the attending and you're going to debrief this team. So you can take notes and we're going to debrief it. Okay? Everybody ready? It's a simulated code.
Hi, Mr. Jones. My name is Michaela. I'm going to be your nurse today. Mr. Jones? Mr. Jones? Somebody I called for a code. I can't feel a pulse. Okay, I got the defense. They're calling a code. Okay. I have the puck. Here you go. If you're... I'm going to plug the pads in. You know, if your compressions aren't effective, it looks like you need to get on the bed. Okay. Why don't you try that? Is that helping? Yeah. Okay. Until I find a stool. As soon as I'm done hooking up the pads, I'll try to get one. Okay. All right. Dr. Cart, do we have a rhythm? We don't. I just attached the pad, so I'm not quite sure what his initial rhythm is. All right, there. We're picking up signal. Can you hold compression so we get a rhythm check? All right, looks like we have to get back on while we're charging. All right, go ahead and clear. And shock. Get back on the chest. 1, 2, 3, 4, 5, 6, 7, 8, 9. Great compressions, Meredith. 15, 16, 17, 18, 19, 20, 23, 24, 25, 26, 27, 28, 29, 30.
Did the thing come undone?
1, 2, 3, 4, 5.
Anesthesia?
We're going to need an airway. Mary, a little deeper, please, on the compressions. I'll relieve you. 20, 21, 22, 23, 26, 27, 28, 29, 30. Great. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, Go ahead and keep doing the compressions while he intubates. I'm right behind you, Meredith. Do we have an airway? A little deeper on the compressions, please. Excellent. Okay, we're switching to continuous now. 1, 2, 3, go. I'll get the backboard. Great swap. Okay. We're going to deliver another shock in 40 seconds. Slow down the ventilations. Make sure you're only doing a breath every 6 or 7 seconds. Tell me when you're ready, Meredith.
We lost the connector. Can you check all the connections, please? Great compressions. There we go. Good job.
Count to 3. 1, 2, 3. Up. Good. Do you want me to get any meds for you?
Excellent. I'd love a milligram of epinephrine.
Sure.
And then we're going to go ahead and charge the defibrillator. Keep doing chest compressions. We're going to take a look at the rhythm.
I'll go ahead and give you...
We're not connected. Can you make sure my pads are on? You keep doing chest compressions. And I'm charging.
1 milligram of epi given.
Excellent. All right, I need everyone to clear so we can do a rhythm.
I'm ready for an expert.
All right, it looks like we've got an organized rhythm. Can we feel for a pulse?
I feel a pulse.
I also feel a pulse.
Excellent. Excellent job. Okay, let's cycle a blood pressure cuff.
Okay.
Okay. So we're going to debrief that. Do we want to do it together as a group, or do people want to split up and have some more?
I can play the role of the first nurse who started CPR as a participant of the resuscitation. I don't know if anyone else wants to. And then,
Maybe we want to do it together?
yeah,
Okay.
just focus on the structure and then
Okay. So I can play the second nurse?
nurse 2 and anesthesia. Okay.
And do a picture. And then we'll also be attending that we're watching back. And we'll kind of set up. And so focus, your goals are to focus on practicing a clinical debrief with that structure. And try that on and see how it goes.
So we're the attending.
Yeah. And so you're
You're the supervisors.
You're like the
So you
unit
weren't-
manager or something.
I mean, the argument of whether you debrief something that you were in or not, you're not in it for this particular simulation.
And could we actually, for the sake of psychological safety, can we turn off the mics for the debrief so that they can practice without being worried that SAEM is recording?
get a different perspective than the one that's already been heard.
I think there's a big difference between, you know, Pam, I'd love to hear your perspective.
Yeah.
And
The framing of it.
Amish, your CPR was terrible. And I think, you know, calling out can mean a lot of different things.
Yeah.
And if the goal of the debrief is to gather different perspectives from the team to create a better shared mental model of what happened and how we can improve on a team and systems level, absolutely. If it's to kind of focus the point of the spear on one individual and blame them for what happened, then no. And if you have sometimes you see someone in a resuscitation do something that boggles your mind, and you want to talk to them about it.
Yeah.
A debrief is not the place for that. A group debrief.
Right.
Hold them aside and you say, "I'm concerned."
Yeah, that's different.
But not in front of everybody.
Yeah, so I think sorry,
Listy.
how you went about it, I think it was, you know, in that frame of like our team work, you said as the team leader, you know, how'd that go from your perspective? I think sort of that preview of like, okay, you're kind of like, not just like, you know, what you think, but like as a team leader, you have that perspective. How'd that go for you? And that's helpful.
So even previewing it by saying, you know, Annemarie, I noticed that you did really excellent CPR here to kind of affirm, like, to be clear about your judgment so that they're not like, what did you think of me? Like, I noticed you did really excellent CPR. I'd love to hear more about your perspective in this case.
Yeah.
To kind of reduce that anxiety around performance. What do you think went well in this clinical debrief?
I thought the team tried to immediately say, well, let's start with the team lead, but you very quickly said, oh, but I wasn't there first. Like you acknowledge that, and so I think letting everybody else in the room talk. I think as the doctor in the debrief, it's easy to take on a lot of that responsibility yourself, right? And then to start with like, well, who was there first? Let's deconstruct this from the beginning. It's a good way to do it.
I thought the group sort of pretty quickly identified what areas they can improve on next time, like the equipment, the familiarity with the equipment, and where the equipment was placed, and what should be on the trolley.
That was the way you guys facilitated the debriefing.
Yeah.
Like, we were just the subjects of the facilitation, right? So I think you're right. The way that kind of you brought that out, I don't know if it came out organically or was it a specific question you asked. I'm having a hard time remembering. Sometimes I write during the debrief. Yeah, no, that's okay.
That's the frame. I stole Amish's seat.
So I guess the question I would ask is, what line of questioning allowed that to sort of come up? And you guys recall? I'm not sure. I can't remember.
I think it was when I was asked about my perspective, and so I knew the case and how it initially started when you summarized the case, but not from my perspective. I came in and I realized that I didn't see a code card.
I think that's a great conversation of the way it shifts from individual performance to team and systems learning of, you know, in the frame of, okay, where was the code card? And then something that our group tried to do was gather the data from these debriefs and escalate them to operations. And so we don't want, when those things come up, you don't want to let them drop. You want to be able to have some sort of system, whether it's just you emailing your clinical service chief to make sure those get wrapped up. So I want to make sure in the interest of time we move on to cover some of the challenges with wellness and second victim syndrome and those things. But any other last thoughts about this debrief before we move on?
Just a quick question about the summary. Is that meant to come from whoever's leading the debrief to summarize? Yeah, okay.
Yeah, so here I think it was nice how Vic did it. I mean, it was soliciting again, like sort of, I like to frame it too as like, what solutions did we come up with? So like, even though they just created solutions 30 seconds ago in your talk, it's nice, I think, to like echo it back if you're recording, to be like, okay, we found that, you know, the code card was not in the best place. We're going to talk about maybe moving it within the unit and adding, you know, a backboard and step stool to it. And usually just like two to three systems issues, then I always do that. And you know, the other things that are on your mind, you can talk to me afterwards. We'll like conclude here, and that's usually when you get kind of like more ideas that come to you sort of inside conversations. So it's nice. I feel like that's a very crucial component. Yeah. To hear people back, like you're listening to sort of what solutions they were creating.
So this was a relatively straightforward case of a code that goes relatively well with no major hiccups. Who's heard of second victim syndrome? Okay, so this is where the wheels kind of fall off the wagon. So this second victims are healthcare providers who are involved in unanticipated adverse patient events, in a medical error or patient-related injury, and become victimized in the sense that they're traumatized by the event. So these individuals feel personally responsible for the patient outcome, though they have failed, second-guessing their clinical skills or knowledge base. So where this relates to this is when we say, how could we have done better in this case? Does that person then go and say, man, if I had done better CPR, if I had gotten their airway, this person would be alive. This is my fault. And when we say, how could we have done better? What is the role of the debrief in the trauma of the provider? And the reality is that we don't know. Nobody does. And so our goal in bringing this up is to highlight that challenge. And going back to your question at the beginning, we don't know. And that's not to say we shouldn't debrief, because what we found in these cases is that people want to talk about these scenarios. So, you know, what is a second victim scenario? Pediatric codes come up as a big one. Medical errors, where there's a clear adverse, or where there may be a connection from an action in a code or in a resuscitate whatever event to an adverse event to the patient. Sometimes it's a patient that the staff knows, or like a staff member. Some other ones that have, they're kind of, you know it when you see it.
Sometimes you don't know it because it's so individualized, you know. It could just be someone having what may seem like a routine stroke, but the provider had a family member who had a stroke a week ago, and it brings back memories, right? So it's just like, it's really a difficult situation.
Right. We brought up earlier, sometimes they're junior trainees. Shannon mentioned like a med student who's like sort of seen, like,
it's their first
time they're seeing anything, and like all like can't really process it in their mind, and then you know they don't really know who to speak to. You just kind of see it out of the corner of their eye that they're a little bit, you know, withdrawn during the shifts.
So I think it's very important when we're doing our routine debriefing to be aware that this is present in the medical environment all the time, and that debriefing interacts with that. Some things to be aware of. This is kind of the progression. So there's kind of the chaos, accident response, intrusive reflections, restoring integrity. That's where debriefing falls in. And they're around the CISD literature. So there's literature that says we shouldn't be doing CISD. That literature is not so good. And we need better literature. And from personal experience, when I have a second victim case, I've tried not to debrief them, and my staff are like, we need to talk about this right now. I'm like, okay, well, we need to figure out how to talk about it. And so I think avoiding the problem is not going to solve it. The clinical staff, and part of it is making the debrief optional. So when I've had these cases, I would say, I will debrief if you want to debrief. If you don't want to debrief, don't debrief. But this is the part where we're talking about. And there's, you know, when you ask, you know, what's the difference between psychological debriefing and clinical debriefing, there is psychological first aid, which is a very different kind of conversation. And there are times when this is what you need to do. And part of that you can see in I included this paper that the CPR for mental health crises. There's an annotation in your handout. If you look under the second one, listen, do not necessarily talk about the crisis event. So part of psychological trauma is intrusive flashbacks, and sometimes when you talk about it more, it makes it worse. So sometimes people don't want to talk about it, but there is an extent to which just establishing what happened, so going through that debrief of like, do the case summary, like what just happened? So, okay, we had a code, someone came in with this is what we did, this is what went well, like this, like, okay, thank you everyone, like just establishing that situational awareness may be helpful. The reality is, we don't know. Like, the literature is so limited. And I've asked everyone I could think of. Like, I've asked the military people, I've asked the PEDS people, I've asked the debriefing people, the after action review people, the CISD people. There's all these different words. We don't know. We don't know what we're doing, but I think, so the key is to be aware of it, to be mindful, and to be aware of the power of performance reflection. So what I do when I have these cases, I don't go into what could we have done better. I skip it, because I don't know the power of that. So I do, when I go back to the structure, let's talk about this. It's optional. What happened? What went well? If it's a feudal code, I say, you know, we did everything we could to help this person, and we couldn't save them. But you did a good job, and you did a good job, and you did a good job, and I do that. And then, like, here are the resources. And just beware of the power of shame and blame, regardless of the intent. So a lot of medical education, like the pimping culture, it shames people even if you don't mean it. So watch out. So time-wise, it's 12:45. We wanted, yeah, you have to go. We wanted to watch this video and talk about it, but timing-wise, let's see. We were going to watch the video, which is like 3 minutes, talk about it, and then close. Are you guys okay? Yeah, so yeah, it's a good video. This is an example of a second victim scenario. It's a code with a bad airway and a bad debrief. It's 3 minutes.
Is it simulated?
No, it's real.
It's real.
Boston Med.
This is a reality TV show. Just contextualize it, was like a second-year resident was called to an inpatient unit as like a rapid response to respond to it. And so it was live and real.
And they're working. There's still a lot that can go wrong.
Yeah, it's really busy. Just calling consults left and right and putting in orders and trying to do procedures. I feel like I'm someone that has to continuously work on my confidence. It's one of those things, if you show a little bit of weakness, people will like prey upon that. So you have to really hold your own.
Hold blue, ED code team, main pipe, B building,
On 2.
What is it?
Dialysis unit code.
Yeah, very good. Anyone have an ABG to get off the Yes.
1 milligram of epi, 1 of atropine. Where'd my tube go? Where's our ES? It's easier to do crowd control in the emergency department because it's kind of like your turf. So when I step out of the emergency department, it's much harder. Dilet and then a swing. Can you get me an EMA from the... Can we get another epi and atropine? Who's drawing meds? There are like 50,000 people that knew the patient that showed up at this code. It was a disaster. All right, hand me the tube, hand me the tube. I need the...
First thing I noticed is that she...
Sorry, hold the tube again. I lost the...
Just started seizing, right? She looked like she was seizing.
When you can't intubate her, it's better to ventilate her.
I never got the tube through.
We needed somebody with more expertise in airway, and because of the delay, she's going to suffer.
So when I first got here, obviously she's obese, and they were saying that she's difficult to ventilate.
So
They're
you
like,
don't
where's
get an
anesthesia?
attending coverage?
We don't get attending coverage, no.
And this is major, it's really not acceptable.
I understand, but I had asked for anesthesia the minute I got here.
So I need to know who's your attending, and I need to talk to him. When we criticize residents as part of the teaching process, that is a very important thing for the resident to be able to accept criticism. Of course, it's a personal thing because, I mean, you're criticizing a particular resident for a particular episode. This is a difficult situation. I'm not saying it's your fault or anything, but, you know, the patient's life is being affected.
No, I understand. It's tough when all you have thought about your whole life is becoming a doctor and, you know, getting through medical school, and, like, you know, you're faced with the possibility of maybe it's not going to happen.
So how would you debrief that? Do you debrief that? I mean, that's...
Not as a group. I mean, like, that, as far as debriefing was the way that this other physician or attending was anesthesia. Yeah, that's a private conversation.
Maybe not like on TV while the patient's coding.
Yeah. Yeah. Are you asking how I would debrief, like, seeing that interaction between,
or even just the
like that. If you were sort of like taken away, maybe you weren't even aware of that side conversation where she was shamed, and then you're like, okay, guys, let's get together.
I'm curious about your thoughts.
Yeah. Well, assuming you didn't know that was that. So you're talking about this is after the event and other staff members are coming in. Well, yeah, it might be difficult, and she might be quite withdrawn or upset. I guess even if you do provide that element of psychological safety during your pre-brief, she might still not feel safe, and it may still be better to talk to her privately, but someone would have to obviously, let you know what had happened beforehand, if you weren't privy to that conversation. So she might still, if you ran your debrief and used the framework and everything, there might be some learning points, but some of those learning points might reinforce her, she's the second victim, I guess, and she didn't call her attending earlier, and so she's going to feel that because that might be one of the things that come out of the clinical debrief, but in terms of her own psychological performance and
Seems
safety,
like it might be a good opportunity for some psychological first aid for her, but not including her in a clinical debrief. But from what we know of this scenario, I think we showed this in a video, and one of our chairs called the chair at that hospital and was like, "What the hell are you doing?" And they're like, "Oh yeah, we don't do that anymore because it was like we don't send our residents to dialysis codes with no attending coverage because that system is incredibly unsafe, and like that's a huge system problem of like it's just not like that's a bad system, and from a systems issue they fixed it."
It's a difficult situation to navigate. Shane said there's no right or wrong answer. I think in our shop, like our PEM group, thinking pediatric codes, a lot of times, like this case is great at highlighting that it's really the system that failed her. She didn't fail the system, right? And there are times that you can conduct the debriefing with a certain amount of structure, even if you're not 100% sure, but you set those ground rules of like, this is what we're talking about. Even unintentionally, you may end up giving her a little bit of psychological first aid because it may not make her feel like it was her fault. And I think that's just been the experience in our shop, that people tend to come together as opposed to like attack each other in the debriefing. But you have to know, like, you have to know your.
I'll relate this anecdote again with, I guess. To me, when I pitched like this video and when we were doing our debriefing, I said, that the Italian, I don't know, Giuseppe or whatever, it sort of also reflects the sort of old thinking in terms of medical error. Whereas like, and what we try, why we do the debriefing is like the current error is that it is like a system that fails you rather than the individual that, they're set up to make a mistake, and it's really, and we're human, so we make mistakes. So how do we create a system that's effective? And there was a nurse, So I conducted like more of like an impromptu side debriefing with a nurse because a patient had extubated himself in the ED twice in one night. It was like on a shift prior to me, and then when I inherited the patient, ultimately we realized that he had a diluted bag of sedatives of like post because it was supposed to be in like 100 cc instead of the 250 cc bag. And when it was found, it was like this nurse felt really bad, kind of beat herself up, and I said, "Listen, I want to debrief this. This isn't your fault. Like, there was something going on. Let's just brainstorm." As like I brought all the nurses around. I asked your permission to debrief it first, but I think this is something we could learn from as to why this happened. And there were certain things in terms of the pharmacy and the fact that we had these bags laying around, or we had different types of dilutants for different sedatives that, like, I really want to know how we can, I know you guys are capable of mixing these drugs. We just want to see how we can, perform better and create a system where we're not put in a situation where these type of mistakes happen. And it went really well.
So it sounds like
yeah, and it got
When we talked about it in the operational meeting afterward, I think pharmacy got rid of some of the other bags and I think we're trying to get 24-hour pharmacy coverage as well, so they don't do it.
But, so things like that where like the culture can kind of like maybe dampen the psychological impact on that sort of like, this is my era that I have to own versus like, what can we do as a system? But there still are going to be psychological impacts.
I think the challenge for all of us is that we all get trained with some traditional shame and blame medical education, and it requires some unlearning. We have to do some unlearning, and that's hard. And it's like the guess what I'm thinking game of medical education that we all get trained on to some extent. We have to unlearn it, and it's hard. So I think we're only beginning to understand how much second victim syndrome, or whatever we end up calling it, is affecting all of us, especially those of us that work in critical care environments, and we see a lot of death and we see a lot of suffering, and it has an effect on us and on our learners, and when we teach, and how do we talk about error in a way that's productive so that we get better. And I think in SIM we work on that, in medical education we work on that, and we're still learning. And this process is really powerful, and we're trying to figure out how that happens. So I think that's even watching the anesthesiologist when he says, it's not your fault. I'm like, dude, you're literally telling me it's your fault. But I don't think he knows that. And I think he has a lot of unlearning to do. So if we hold the assumption that he's trying to do the best thing for the patient, and he's trying to say, I need to talk to the attending, I know it's not your fault, but it's so harmful. And ultimately that person, I think, ended up leaving emergency medicine. And I don't know if she did. I don't know how much of it was because of that incident, but that was devastating and career-ending. So we just need to be mindful, and we don't. The literature is.
Well, that's the struggle. I think that's what we're all struggling with clinical debrief. Even those of us who are seasoned simulation educators, it's there is so much more, psychological.
The mannequin doesn't die, the patient does.
That's right. And it's real life. And it's real life.
It's different.
So that's the real challenge. Yeah, sure, we can, you can get learning points, teaching points, but that's, you spend more time dealing with the emotions.
And we've been doing this for 4 years. We have been talking to people at the cutting edge of this field. We're all learning together.